So while initiation of ECMO, what are the ideal steps is, first you have to prepare the relatives, you have to counsel the relatives, take the consent from the relatives. Second is team preparation. Third is the circuit preparation. Fourth is patient preparation, then cannulation and heparinization. First step is relatives preparation and counseling and consent. In team preparation, you have to define the goal and strategy. The role of each member has to be clear, who is going to do what. Circuit preparation, select a proper circuit and priming that we have discussed. And patient preparation, you have to adequately support the patient, adequate volume status, adequate inotropic supports and ventilation so that they don't deteriorate during the time of cannulations and initiation. That is most important. Any surgical procedures like minor tracheostomy has been done, or change of lines has been done, or any major operation that needs to be done, that has to be all kept in mind while you are giving heparin dose and heparinization. Cannulation, the size of the cannula, the site and the technique of cannulation, that has to be kept in mind. And you have to plan how much heparin you want to give as a bolus and initiation. When you initiate ECMO, what are the parameters you are going to set? As I told you, what we are going to set is the blood flow rate, that is you are going to adjust with the flow RPM. So you increase your RPM and set the blood flow rate. You do the sweep gauge, adjust the sweep gauge so that you know how the CO2 level has to be maintained. You have to adjust the temperature of the reticulator unit and set the alarm so that if there is anything, it gives you an alarm. What is most important point is when you are using a centrifugal pump, remember centrifugal pump is not an occlusive pump. So what happens if you have kept both the lines open, the blood will go in a reverse direction from artery to vein because of the high pressure to low pressure. So it is not an occlusive pump. So always you have to increase the RPM to 1000 and then release the arterial side flame. Otherwise it will be, flow will be in the reverse direction. So always first increase the RPM to 1000 and then release the arterial flame. That is most important, you have to keep in mind. If you try to do the same thing with the roller pump, you get a tube rupture. So always we have to keep in mind it's a centrifugal pump. Put the increase the RPM to 1000 and then release the flame. Immediately once you initiate the ECMO, what is first thing you should see is you see the venous and arterial tube color. That's most important. Okay. As soon as you initiate it, you see the difference of the color. If both the tubes look same color, it means if both are dark, it means your oxygenator is not functioning, or somebody has forgot to connect the oxygen to the oxygenator. That is a possibility. So always check the color immediately as soon as you start. If both are too bright, that means there is a recirculation occurring. So that is what is most important. So as soon as you initiate an ECMO, just see the tubings, venous tube color and the arterial tube color. See look at the SpO2, whether SpO2 is increasing or not. Look at the vitals. Whenever you initiate an ECMO, there will be always the transient hypotension and bradycardia. That has to be kept in mind. You have to keep yourself patient, target the heart rate, and then ask the supporting staff. Without your instruction, they don't give anything. Usually what happens, they start going bradycardia, immediately the staff gives atropine or something, and then the patient goes into a tachycardia, and again, if it's a VV ECMO, if there is too much of tachycardia, the cardiac output is not going to be that good, so there will be a chance of recirculation increases. So that has to be kept in mind. So you have to, and it's usually a transient phenomena which remains hardly for a minute or two, and then it recovers by its own. So you don't require to, what you require to do is just give some fluids, because you are replacing the blood by fluid, so you have to be just infusing some fluid during that time. That's it. Then get an X-ray done, X-ray chest, and if required Doppler to confirm the position of the tubes, and monitor the circuit pressure. That is what is most important thing. Come down to rest ventilator settings. The moment you increase the flow, the saturations are fine. That does not mean you stop there. Start coming down on ventilator settings. Okay, get to rest ventilator settings. Once you come to rest ventilator settings, your saturation is going to go down. So you go up again on the flow and get the adequate flow, adequate saturations with the rest ventilator settings. That is what is most important. Okay, and then you decide about your staffing pattern. You put your all emergency cart again ready, refill whatever you have used so that it can be used in an emergency, and fill up the data set. That is most important. Documentation is most important. In team preparation, goal and strategy you should decide, and role of each members. Goal, what is important is adequate oxygenation and tissue perfusion. That is what is the more is inadequate. We don't want the saturation to be 100%. adequate is 90% saturation is good enough for a VV ECMO. To decrease the ventilator damage by ventilator rest settings, to decrease the inotropes, and what is most important, which we are inclined by initiating ECMO is to give rest to the heart and lung. Strategy, you should decide type of ECMO, size of the cannula, circuit timing, what we are going to use, how much we are going to use heparin, what acidity level you are going to accept, whether 160 to 180 or 180 to 200. It depends on whether the patient is posttraumatic or bleeding tendency is there, or the patient is actually surgical and is there some bleeding, you might even come down to acidity to 140 to 160. So that depends upon the case to case. You have to decide and plan your strategy and instruct your staff accordingly if you want to maintain acidity at this level. And if the acidity is fluctuating too much, you might have to do every hourly. Once the acidity stabilizes, you can do it every 2 hourly or 4 hourly also. Maintain mean heart rate pressure, oxygen and tissue perfusion. Flow rate usually 60 to 100 ml per kg for VA ECMO and 100 to 120 ml per kg per minute for VV ECMO. And flow rate is decided by two important factors, that is oxygen delivery and cardiac output needs. Okay. That is the thing which is going to determine your how much you want to give a flow. Minimum you require 3 members to support you. One will help you in cannulation. Okay. One is going to take care of the circuit. And one person is going to remain with the patient for medications, for heparin, bolus, fluids, and resuscitations. So there will be the entire responsibility of managing the patient is going to be on one head. Second one person is going to look into the circuit, and the third is helping you for cannulation. So you should have a proper planning, and all the staff should know their job. You should not have to, while cannulating, you don't have to shout for them, give heparin. They should know that yes, once the virus is going inside, they have to give heparin, and they have to be ready with all emergency medicine and everything. Mode of research depends on the indication for ECMO, availability of vascular access, and cannula size. Circuit preparation, we have discussed circuit selection and circuit timing. Okay. Patient prescriptions, again we have already discussed. Adequate volume status, usually initially when you initiate ECMO, most of the time we go by try to keep the patient dry in ICU. So we usually underfill them. But when you are initiating ECMO, you have to give fluids. Especially for 24 to 48 hours, you might require to give good fluid because we are in SARS kind of reaction. So you have to give some fluids initially. So optimize the volume status, optimize the inotropes and ventilation so that they can sustain the procedure well. Again, as you can keep in mind, it will require some kind of surgical procedures, or whether it has been done just before you have done everything. And see to it whether you have checked for the pre-ECMO checklist. All the checklist has been checked. Before inserting ECMO, note the vital parameters before you start in ECMO. See whether pre-ECMO investigation like blood gas, CBC, clotting parameters, electrolytes, everything will be done. Confirm the availability of blood which is there. Even if your hemoglobin is fine, you should see that some amount of blood is always reserved and you can get it if you require any emergency. Stabilization of patient, infuse the adequate fluid required in most of the cases. Usually you keep dry patients, ECMO related surge is always there. Types of fluid, either you can use crystalloids or colloids versus blood. That depends on the hemoglobin level and patient status. Adjust the inotropes and adjust ventilator. What are the checklists you are going to check before you initiate ECMO? Check whether cannula is well secured. Look for any bleeding or hematoma around the cannula site. Check all the connectors are properly tightened, and preferably if you have a tighten, you put a tighten so that it doesn't come out. Check all the ports which are blocked. So whatever the connectors you have kept it, whether we have been put the blocks on it so that there cannot be a leak from there. Connect the pressure tubings to the pressure lines so that you can immediately monitor the pressures of the circuit. Connect a flow sensor to the flow meter in a proper direction. So once you start in RPM, you can get the good flow, able to see the flow. Okay, the calibration machine has to be done much before that, and start circuit to recirculate with the flow of. But once you prepare the circuit, time the circuit to keep it in a recirculation so that the blood flow is maintained. You even know you can remove microbubbles. Related preparation, consent and counseling that you have to take it. Most important, when you take a consent, you should include the statistical benefits as per the ELSO standards. So you should be able to tell them how much is chance of survival. And in most of the time, I make it very clear. See, I always tell, and all of you must have experience in ICU, the only time when you are in upper hand is when the patient is critically ill and you are going to offer them some treatment. The moment you started doing some procedure and you offer some treatment, they become in upper and you come down. So whatever you talk on day 1, they are going to listen to you. And day 2, day 3, day 4, they are going to cross question you always. Why is it not improvement? What has been done? We have spent so much. So all that grumbling will come. So whenever you want to take a consent, you should always talk in a proper, with all statistics that is portfolio. So statistical benefit as per the ELSO guidelines has to be. You explain them all complications related to ECMO, especially the bleeding in the brain, in the embolic phenomena. They don't mind. Now, if there's a patient, even if a patient survives and that survives with an amputation, that is going to be a very ugly sign and they will blame you for that. So you have to always tell them all the possible complications, also the treatment, and roughly the duration of treatment. That is most important. In many of the cases, especially initial cases when I have to go out of the hospital to do an ECMO, and the primary consultant always used to tell me that we have already talked to them in details about the ECMO and treatment, everything. And then after third day, the patient will say, why is not improved? So you have to make it very clear that okay, this is going to take roughly 10 to 15 days time. It's not going to be 2 days or 3 days. That is what is usually in their mind. This is going to be, ECMO is going to be for 3, 4, 5 days. So you have to make it very clear, especially in a respiratory ECMO is going to take a time. In that again, H1N1 is going to take more time. Usually statistically we found that I know on an average length of an respiratory ECMO is around 8 to 10 days, and if it's an H1N1, it still take a longer time, around 2 weeks or 2 to 3 weeks. So that you have to tell them very clearly. Counseling is very important. Should include mechanism of action of ECMO, how ECMO is going to work. I usually make it a first point to tell them that ECMO is not the treatment for this patient. It's not going to improve. It's just a bypass road. They are just trying to buy some time till the time the organ recovers. If organ recovers, well and fine. If organ does not recover, make this recover to kill the swine flu. That is what is most important. To make it very clear. Potential benefits versus risk, duration of stay, and possibilities of communication due to the medical reasons. So all these steps are very important. You should know. And now is the initiation of VV ECMO. The same related. See, this is a flow soaring machine. So I put the flow sensor on the arterial side near the cannula. You attach the flow sensor. The RPM 20. We have still not opened the clamp, so the flow is 0. So arterial clamp is still on. You increase RPM. This is the patient's pressure. This is the patient's blood pressure. Okay. Saturation probe is moved. The saturation around 91. This is the ventilator settings before we initiated ECMO. 100% FiO2, PEEP of 15. So we have removed the arterial side clamp. See the color of venous cannula. Venous cannula color, dark, very dark. And see the arterial cannula, bright red. So that's the first thing you have to observe, the venous tube color and the arterial tube color. When you feel both color difference is good, it means everything is fine. Okay. This saturation has come up immediately to 97. Blood pressure is improved. As soon as the hemodynamics improve, oxygenation improves, hemodynamics improves. And now we start coming down on ventilator supports. See the flow is with 1000 RPM flow is 1.7 liters. That is usually you see in VV ECMO. In VA ECMO, because the arterial resistance is there with 1000 RPM, you might be able to see the flow of around 1.2 to 1.3 liters. So this is the RPM, 1004. This is the flow, 1.7 liters. This is the flow, 1.76. Okay. Look at this is the flow sensor. I have kept the flow sensor around 800 ml. Liters here 0. 800 ml. So usually we start with a 0.5:1 ratio, and then gradually once we increase the blood flow, we increase the sweep gas also, and this is to prevent sudden drop in the CO2 levels. That is what we wanted to show you, the flow with the sweep gas ratio. See, the saturation is now 88 because we have put a patient back on rest ventilator settings, so saturation is decreased. Most of the time we found that the blood pressure increases when the patient we put on ECMO. So the mean blood pressure is going to 116, and many times you are able to get rid of inotropes, and sometimes you even have to put some them on antihypertensive like NTG or low. Okay. See, this is the pre-pump pressures, minus 18, the pre-pump pressures. So that is again, pre-pump pressure is fine, adequate, so less chance of hemolysis. So the ventilator settings, we have come down to F5 of 40, respiratory rate of 10, P4 12, and peak pressures we are restricting to 14 plus 12, 26. That is the ventilator settings. This is the, we measure pre-pump pressures, pre-oxygen and post-oxygen. We connect it to the one line only. We always keep the pre-pump line open so that we can measure that pressures. While pre-oxygen and post-oxygen line, we every hour we open and check the pre-oxygen and post-oxygen pressures. Flow is 4.6 liters, RPM is around 1900. That ratio you should always remember, 1900 with a flow of 4.6 liters. And see, now the sweep gas has increased to 2.5 liters. So as you increase the blood gas, blood flow, you will increase the sweep gas also accordingly. And see, this again I told you, the most important is, yes, U-set has to be maintained whenever you are doing a neck cannulation. See the dressing, if your puncture is clear and there is no hematoma, you can just put a transparent dressing over it. You don't have to put a Dynaplus. Unless you find it as a multiple puncture and there are chances of hematoma, then you have to give a compression bandage. Otherwise, just put a simple transparent dressing, that should be enough. So the color difference between arterial flow and the venous flow. So that is what the initiation of VV ECMO. Now initiation of VV ECMO, the same ECMO which you have, the cannulation what we have seen is a continuation of same video of Iran. So we have kept the artery line clamp. Now we are removing the air bubble from this line, and this line is going to be connected to the distal perfusion cannula, which has been put through the anti-gate puncture. The 7-fence cannula which has been put. Once we re-bubble it, we'll put it. We have connected it now. We'll open it. Mean pressure 1780 by 48 is a mean pressure of 60. And now we are initiating ECMO. We are removing the femoral venous cannula, femoral artery, again rechecking the whether this cannula has been properly fitted, tight. Okay. Removing both the cannulas. See, he has kept the arterial cannula at the pump head. So we are removing these two cannulas here because the coffins that they kept the cannula there. See, here the flow is again around 1200. And see, now he is removing the arterial clamp from here. Yeah, he has removed the arterial clamp. Now the flow will start because 00 first. And now see, the flow is around 300. And then we have to increase the flow. RPM will increase the RPM. And moment we increase the RPM, the blood pressure starts coming up. Now flow is 1.3 liter, and see the RPM is 1200. So usually when the arterial, the flow is, the RPM is going to be higher as compared to venous because the resistance is low. Gradually the pressures will improve and Depending on that, we keep on giving them the more flow. We'll increase the flow till the time we get an adequate pressures. Pressure is 75/45. Saturation come to 100%. He is giving some blood to the circuit. Usually we don't prefer to give blood to the circuit, we always give blood to the central line, but it is being connected, so he is giving the blood to the circuit. Yes, it has to be connected pre-pump. Post-pump the pressure is going to be very high, so we cannot connect. It has to be connected pre-pump only. But then usually we don't prefer to connect anything to the circuit and give anything to the circuit, unless it's a dire emergency. But otherwise, no. Infection as well as there's some chance of air can go inside and so that is the problems. So gradually now we'll increase the flow. This is gradually coming up 85/49 50. What you are seeing is we have made the balloon pump 1:3. Whatever the spike you are seeing was the beta was balloon pump, which was initially 1:1 and then we make it 1:3. Okay.